It's a real pleasure to introduce Zaneta Thayer. She's an assistant professor at Dartmouth College in lovely Hanover, New Hampshire. She works on a variety of different topics that include developmental plasticity and health, minority health, and health disparities. So Zane, I hope you will keep in mind that special issue I just mentioned, social factors that influence maternal health. And she's worked with several indigenous communities, notably in New Zealand, and also reservation communities in Northern Plains Indian tribes here in the US. Zane received her PhD from Northwestern and also got her undergraduate degree at Dartmouth College, where she's, as I just mentioned, is currently an assistant professor. So with that, I'll turn things over to you, Zane.
Cool.
Thanks for joining us today.
Thanks for having me. All right, let me go ahead and share my screen. Okay. So hello, everyone. It's great to be here today with you. So what I'll be presenting today are some data that I'm hoping to submit soon for publication and the groundwork for a larger theoretical project I'm hoping to get off the ground. So I really welcome feedback as this is a work in progress. So this project has really been motivated by a course I teach at Dartmouth called The Evolution of Pregnancy, Birth, and Babies. As part of this course, I ask all the undergraduate students the following question. What are the words that come to mind when you first think about childbirth? Without fail, I tend to get a laundry list of terms that generally are associated with things like pain and fear and blood and screaming. It's all quite negative. I then tend to ask my students, how many of you have seen a childbirth? And most of the time, none of them have. And yet they all have the exact same image in their mind of what childbirth looks like. And it's generally some iteration of a woman screaming uncontrollably while laying on her back in a hospital bed. So this image in their mind has obviously been greatly shaped by scenes of childbirth in movies. Given the similarities in their responses, I've become fascinated with whether and how the expectations we have for childbirth, specifically the expectations of fear and pain, how those expectations can actually affect the physical experience of childbirth. What's more, since it's likely that these expectations for childbirth vary across cultures and is likely also varied across our historical and evolutionary history, I'm interested in how these differences in expectations could shape differences in childbirth experiences across space and time. So something alluded to by my students' responses, and which is remarkably prevalent, is what's known as fear of childbirth. This is a concept that was clinically defined by the Scandinavians in the 1990s. The majority of research on this topic still found in Northern and Western Europe, with some studies also coming from Australia and Canada. Based on this work, an estimated 10% of pregnant persons have severe tocophobia, as it is known, and this is clinically recognized in parts of Europe as a type of phobia. Tocophobia is so severe in some instances, people will actively avoid even becoming pregnant, which is obviously not very good from a fitness perspective. In one study, 9 to 11% of pregnant people report having postponed the current pregnancy due to fear or had considered ending it through abortion. Moderate fear of childbirth is estimated to occur in more than 1/2 of pregnant persons, and as I will argue in this talk, can be a considerable source of stress across the perinatal period. So why are some individuals afraid of childbirth in the first place? Well, of course, childbirth is not without risk. And unfortunately, on a global level, many individuals die every year in childbirth. In the US, importantly, within the US, maternal mortality has actually increased by more than 130% in the last 25 years. There are also substantial inequities. Black women 3 times as likely to die as white women in the US, and Indigenous women twice as likely to die. Given this, Rosenberg and Trevethan, in an article exploring the causes and consequences of cesarean section, published in EMPH, have actually proposed that having a little fear of childbirth may actually be an adaptive and appropriate response to facing the potential risks associated with childbirth. Specifically, a little anxiety about childbirth encourages seeking assistance in labor and is a good thing. However, severe fear of childbirth may reflect an overactivated defense mechanism, basically an inappropriate level of fear in response to childbirth. What's more, they also argue that there may be a mismatch between evolved birth conditions and biomedical birth experienced in cultural contexts such as the US. A remarkable near-human universal is the evolution of birth attendants. Many individuals likely knew these birth attendants well as extended family or community members, and individuals were likely continuously supported by others during labor. This contrasts markedly with the biomedical birth environment that has emerged over the last 100 years in the United States. Today, 98% of births in the US occur in the hospital, and individuals are often giving birth with nurses or sometimes practitioners that they are meeting for the first time. High rates of medical interventions, such as cesarean, increase the fear of complications arising and harm coming to either the mother or her child. Laboring persons commonly face restrictions in mobility in order to be hooked up to fetal monitors, even when it's not medically indicated, and may be discouraged from eating and drinking freely in case a cesarean is needed. Patients are also commonly primed or even described being pressured by providers to use pain medication in labor, potentially undermining their confidence in their ability to handle their own labor pains. While there have been efforts to increase patient comfort in hospitals and address some of the non-evidence-based practices I've mentioned, there are nonetheless persistent complaints about providers failing to respect individuals' birth plans. These issues are amplified for women of color, many who fear and actually experience provider mistreatment. In some, many pregnant persons are more afraid than ever of anticipated childbirth pain, of unexpected complications arising, of not having adequate emotional support in labor, experiencing poor treatment from medical staff. So going back to the idea of fear of childbirth mentioned by Rosenberg and Trevethan in the context of cesarean, my own background in maternal stress during pregnancy made me wonder whether, given the pervasiveness of many of these fears, if the impacts could be even broader than cesarean, and that this may actually be an important stressor with impacts across the perinatal period. What I would therefore like to spend the next few minutes discussing are some of the ways that I imagine fear of childbirth could be impacting maternal and child health across pregnancy, during childbirth, and also during the postpartum period. So I wanted to start with pregnancy. First, I'd like to make the case that we should view fear of childbirth as a potentially important source of stress in the prenatal period, similar to how we are beginning to accept the impact of other major life stressors, poverty, and discrimination. While there are no studies that have directly evaluated fear of childbirth in relation to cortisol, an important HPA-axis hormone, in pregnancy, studies have evaluated the relationship between pregnancy anxiety, which captures many of the fears and concerns associated with fear of childbirth, in relation to cortisol. In one longitudinal study, researchers measured cortisol at multiple stages of pregnancy. They found that individuals with higher pregnancy anxiety had higher increases in salivary cortisol across gestation. This is notable since increased maternal cortisol can have wide-ranging impacts on fetal development. As one example, in a phylogenetic meta-analysis across vertebrate species that all share the HPA axis, we previously reported that higher maternal stress and higher maternal glucocorticoids, an HPA-axis hormone, are associated with elevated glucocorticoids in offspring. Elevated glucocorticoids in offspring could, in turn, affect things like growth rate, metabolism, behaviors, and long-term health in offspring. What's more, maternal stress and elevated HPA-axis function have also been associated with timing of parturition, or the length of pregnancy. As one example, data from 282 pregnant women were analyzed to investigate the effects of maternal prenatal anxiety and CRH, a hormone in the HPA-axis, on the length of gestation. Women with more pregnancy-specific anxiety had shorter gestation length, and these effects were significantly mediated by elevated CRH. While it seems plausible that fear of childbirth could be associated with lower birth weight and/or short gestation length, to date, this has only been evaluated in 2 studies that both had various methodological issues, leaving these hypotheses not well evaluated. There are also, of course, potential impacts of fear of childbirth on cesarean section, as described by Rosenberg and Trevethan. So cesarean section rates have notably increased across time, both in the US and in other cultural contexts. Currently, about 1 in 3 births in the US is by cesarean, which is about 2 to 3 times what the WHO estimates is likely to be medically necessary. So there are a couple of ways that fear of childbirth can lead to increased cesarean. One of this is through maternal request of cesarean. Specifically, women with childbirth fear may perceive cesarean as a way of enhancing control over the birth process, offering safety and alleviation of fear. In addition, fear of childbirth can also lead to increased cesarean through less direct mechanisms, including stress-induced impacts on duration of labor and higher perceived pain. And I'll describe each of these more now. So first of all, duration of labor. So several researchers have proposed that fear and anxiety have been hypothesized to affect labor duration. And this is something that a lot of birth practitioners will describe as well. So there are some studies that support this with empirical data. As one example, there was a study out of Japan where they compared individuals who had high and low fear of childbirth and found that individuals with higher fear of childbirth had longer duration of labor. What's interesting is that in the animal model literature, there are also similar sorts of studies which find that stressful experiences during labor actually prolongs labor. So these are data from dairy cows, where cows were moved during labor, which is a stressful experience. And dairy cows that were moved during the late first stage of labor had a longer length of second stage of labor. So in humans, fear may induce superphysiological levels of catecholamines, such as adrenaline and noradrenaline, and or endorphins, and this may inhibit labor progression through both direct and indirect mechanisms. This longer duration of labor may increase C-section risk due to outdated use of Friedman curves, which set a recommended length for labor. In addition, mothers may simply become exhausted when labor is exceedingly long. Fear can also have important impacts on pain perception. So research in neuroscience has demonstrated that fear is known to impact pain perception more generally. And there's really interesting studies that show things like trust or support from others actually lead to lower pain perception due to reduced fear. Within the childbirth literature, one of the first articulations of the potential relationship between fear and pain was by Grantley Dick Reed, a British obstetrician who published his first books on the subject in the 1930s. He specifically proposed the fear, tension, pain cycle, where fear led to increased tension in the uterus and the cervix, which slowed labor progression and also increased pain experience, which then led to more fear. So it's kind of this terrible negative feedback loop, positive, negative feedback loop. So Dick Reed actually argued that by educating pregnant people about labor and eliminating fear, that individuals could actually have a pain-free birth. Similar approaches were developed in the USSR by Velvosky and colleagues. What they described as a psychoprophylactic method for painless birth was later exported into the West as the Lamaze method. So there's some evidence that fear of childbirth can affect perceived labor pain. Data from the same Japanese study I mentioned in relation to labor duration suggests that individuals with higher fear of childbirth have higher perceived pain across different stages of labor as well. Finally, I would argue that fear of childbirth is likely to have currently underappreciated impacts in the postpartum period as well. To the extent to which individuals with high fear of childbirth are more likely to have or perceive their birth as traumatic, this could clearly increase risk of developing PTSD in the postpartum period. In addition, C-section, stress, pain, and adverse mental health after fear of childbirth can also potentially affect breastfeeding initiation and success. So I've been thinking about all these questions and getting interested in thinking about ways to test these different hypotheses when COVID happened. As many of you have likely read about in the news, the pandemic has been extremely disruptive for prenatal care, labor, and delivery experiences. These impacts have been experiences have directly impacted many of the factors known to underlie fear of childbirth. Specifically, individuals were limited in the number of support persons they could have with them in labor, oftentimes having to choose one person between their partner or their mother or their doula. Another important stressor was threat of separation from newborn. Specifically, in the US, it was recommended that moms who tested positive for COVID be separated from their infants at birth. This was inconsistent with WHO recommendations and was a huge source of anxiety for pregnant persons. There was also stress about pain management strategies being affected. For example, many hospitals ceased nitrous oxide use, which was another source of stress for moms. So some questions I therefore wanted to address through data collection were, first, how has the COVID-19 pandemic impacted fear of childbirth? I was specifically interested in if the pandemic has exacerbated fear of childbirth, since it would seem that the conditions under which individuals were having to give birth would only be exacerbating the mismatch in birth environments described by Rosenberg and Trevethan. Second, if fear of childbirth has impacts across the perinatal period as predicted in the model I laid out, are perinatal outcomes associated with fear of childbirth? So data that I'll be describing now come from the COVID-19 and reproductive effects study, which is a study that I co-designed with Dr. Teresa Gildner at WashU in St. Louis. And this data collection and all the effort has been supported by a wonderful army of research assistants. So the CARE study is an online convenience sample of US-based pregnant people, and we have data on over 1,800 births. Individuals completed a first round questionnaire in the prenatal period, and again, a postpartum questionnaire about 4 weeks postpartum. We recruited participants through social media, so it's a relatively biased sample. In particular, it's predominantly white, highly educated, and high income. And you can see more about our participant demographics in some of our prior publications. So the first measure I wanted to talk about, of course, is fear of childbirth, which was our main predictor variable. The way that we measured this was through the fear of birth scale. So participants were asked, how do you feel right now about the approaching birth? Please mark with the slider on the lines below. So this is a visual analog scale, and participants, there were 2 different questions. One was anchored on calm to worried, and the second was anchored on no fear to strong fear. And so we assigned values of 0 to 100, and we averaged the response to these 2 questions to create a fear of birth score. We then asked participants about how much they agree or disagree with the following statements. Specifically, we asked about if participants were concerned about if they would catch COVID-19 and it would affect during pregnancy and if it would affect their baby, if they were concerned that they would catch COVID-19 and it would cause them to be treated poorly by their medical providers, if they were concerned about catching COVID-19 and passing it to their baby in pregnancy, if they were concerned about whether the pandemic would affect the amount of labor support they would have during delivery, if they were concerned that their baby would be taken away at childbirth because of a positive COVID test, and finally, if they were concerned about any potential long-term effects of COVID infection on their child. So first of all, what was the prevalence of fear of childbirth in our sample? So on the right, you see a histogram that demonstrates the distribution of fear of birth scale scores within our sample. The median score was 65.5. And according to a cut point of 54, as has been described for previous use with this measure, 62% of our sample had significant fear of childbirth. I should mention this is much higher than has been reported in many other studies in Europe and Australia, for example, which tends to find that about 20% of participants have significant fear of childbirth. We found that having lower education, being lower income, being single, having an obstetrician as opposed to a midwife, having a high-risk pregnancy, having this be your first birth, being later in gestation when you took the survey, and having prenatal depression were all associated with higher fear of childbirth score. And these were all more or less consistent with prior research as well. We then looked at the specific COVID-19 concern variables that I mentioned, and what we found was that participants who agreed or strongly agreed with those different concerns all had significantly higher fear of childbirth scores. In particular, if participants agreed or strongly agreed with these variables, they had 10 to 18 point higher fear of childbirth score out of 100. So as a couple of examples, participants who said that they were concerned that they would get infected with COVID-19 and that it would affect their baby, they had a mean predicted score of 61 compared to the 48 for those that didn't agree. Concerned that you would not be able to have your preferred support persons in labor due to the pandemic. Individuals who agreed with that had a mean score of 62 as opposed to 49. Those who said that they were concerned if they tested positive for COVID-19 that their baby would be taken away, that they had a mean predicted score of 63 compared with 45. So we then looked at whether fear of childbirth was associated with our various birth outcomes. So what we found was that high fear of childbirth was not significantly associated with likelihood of cesarean section. And this was true whether we looked at planned or emergency cesarean. So this was not consistent with our predictions. We then looked at fear of childbirth in relation to birth weight. And what we found was that higher fear of childbirth was associated with significantly lower birth weight in unadjusted, but not in adjusted models. Finally, we found that high fear of childbirth was associated with significantly shorter gestation length in both unadjusted and adjusted models. And this was the case if we looked at fear of childbirth modeled dichotomously, or if we looked at fear of childbirth measured continuously as represented here. So again, individuals who had higher fear of childbirth, they had a shorter length of gestation. So they gave birth to babies a few days earlier. We then looked at fear of childbirth in relation to postpartum outcomes. What we found was that high fear of childbirth was not associated with breastfeeding initiation or intended breastfeeding duration. We did find that higher fear of childbirth was associated with increased likelihood of formula supplementation, with individuals with high fear of childbirth having an odds ratio of 1.7 for using formula compared to those with low fear of childbirth. Finally, we found that high fear of childbirth was significantly associated with higher postpartum depression. And this was again true whether we looked at fear of childbirth dichotomously or as a continuous variable as represented here. So there was a very strong relationship between higher fear of childbirth and pregnancy being associated with postpartum depression. So in sum, we found that lower education, lower income, nil parity, obstetrician-led care, depression, high-risk pregnancy, and greater gestational age were associated with higher fear of childbirth in this sample. We also found pretty strong evidence to suggest that COVID-19 was associated concerns were associated with higher fear of childbirth. And this led us to interpret that COVID-19 may be exacerbating existing fears individuals already have coming into childbirth. And I think that this interpretation was very well supported by comments from our participants. As an example, one participant wrote, "I'm terrified all the way around as it is my first pregnancy. You name it, I've worried about it. The COVID-19 stuff just adds more fear." We also found evidence to suggest that fear of childbirth has impacts across the perinatal period. Specifically, we looked at associations between fear of childbirth with gestation length, birth weight, cesarean section, postpartum depression, and breastfeeding behavior. So we found evidence to suggest that fear of childbirth is associated with shorter gestation length. We failed to find a relationship with birth weight and with cesarean section. We did find strong evidence to suggest that fear of childbirth is associated with higher postpartum depression, and it was also associated with increased likelihood of formula supplementation. So I wanted to go back to a point I mentioned earlier about how inequities in maternal mortality in the US, and specifically the fact that Black women have maternal mortality rates 3 times higher than white women in the US. Women of color have been wronged by the US healthcare system, and this understandably leads to more fear of childbirth in this system. Here are a few quotes from our participants. One participant wrote, "Black women are more likely to have complications or die in childbirth. I'm even more concerned about that during COVID because I could possibly not have an advocate, my husband or mom, in the room when I give birth. Who's going to speak up for me?" Another participant wrote, "I'm concerned about not having my doula there in the room and experiencing racial discrimination that jeopardizes my health and my baby's health." Individuals who fear unfair treatment and discrimination in obstetrical settings likely have greater fear of childbirth, which the argument I've outlined here could increase risk of complications across the perinatal period. We therefore need to improve the maternity care system so people do not have to feel this fear and develop associated health sequelae. Moreover, I think it's worth noting that the majority of fear of childbirth research tends to view fear of childbirth as indicative of individual psychopathology. However, what the results of our analysis suggest is that there are likely both individual and sociocultural factors that shape fear of childbirth. I think this interpretation is consistent with the idea of mismatch as proposed by Rosenberg and Trevethan, since cultural context of birth today is very different than that which was likely present for much of our evolutionary history. And the COVID-19 pandemic has really just amplified those differences. In this sense, we may therefore interpret moderate fear of childbirth as an adaptive response to the modern cultural context of birth, since after all, it makes sense to be afraid when you're giving birth in a setting that does not feel safe. Unfortunately, feeling unsafe in those contexts does not necessarily improve outcomes. I think there are also several clinical implications of this work. One thing we really need to focus on is increasing perceived safety in the birth environment, which evidence suggests is greatly helped by having strong emotional support through labor. Another practical clinical application would be screening for fear of childbirth during prenatal care. Although I imagine actually doing this would be difficult, since there are already issues of insufficient depression screening during prenatal appointments. I think it's worth mentioning that in some Scandinavian countries, individuals are screened for fear of childbirth as standard of care, and individuals with high fear of childbirth are referred to specialists to treat the condition. Finally, a recommendation from Dick Reed, Lamaze, and other psychological-based methods for reducing fear and pain in childbirth emphasize the importance of childbirth education. Therefore, reinforcing or creating familiarity with childbirth is important. An interesting hypothesis arising from this assertion in my mind is that folks who may be more exposed to childbirth because they're in families or communities with higher fertility, and or those who observe childbirth in more supportive or community-based settings may have lower fear of childbirth. Moreover, I view these data in my presentation today as just scratching the surface. I think there's a lot of work that needs to be done. I'm excited to discuss this project at this stage with folks in the audience to get some feedback as I move forward and further develop these ideas. In addition, I would love to chat with folks who are working in different cultural contexts to explore meaningful ways of collaboration, as I'm quite interested in understanding these dynamics in places where the cultural models and expectations for childbirth differ, as well as in places where maternal mortality risk also varies. So I want to say thank you to a number of people. Thank you so much to the study participants for providing their insights and knowledge and experiences with us. Thanks to Teresa Gildner and the rest of the CARE study team. Thanks to Ali Geisel-Zamora and Katie Fearon, two Dartmouth undergrads who helped me with a lot of the background for this presentation. And thanks to my students, the Claire Garber Fund for funding our study, and the Wintergreen Hunt Award for supporting me during my work. And lastly, thanks to my baby girl for providing me with an experiential learning opportunity about the importance of feelings of safety and trust in childbirth. Thank you.
Thanks, Zane. That was fantastic. Thank you for a great presentation. We have plenty of time for questions. There are some great questions in the chat box, and we also want to hear from people in the audience. So we'd love to see some people raise their hands before we start going into the chat box. If you have questions, even if it's already been in the chat, I think it's good to have it as a discussion and share that with Zane and get her perspective on it as well. I might just start with a quick question, which relates to the beginning of your talk. And I'm wondering what you tell your students, what the level of fear is in the classroom compared to what it was in your survey, and what you tell your students in terms of the fear of childbirth, and if you have any metrics that suggest you can reduce that or modify that over the course of a Dartmouth quarter.
I really wish I did pre-post, had pre-post data on that class now. I don't have those statistics. I'd like to think that students in the course, some of whom I think are in this talk today, get an appreciation for the fact that, again, a lot of people have this idea of what childbirth looks like. And then you think, well, what are these ideas actually based on, right? And it's actually based on the way that what we see in the media, really, right? Because most people in our culture don't have a lot of experience with, firsthand observation of childbirth, and certainly not firsthand observation in childbirth in any community-based sort of settings. So I'd like to think that the students learn that there are different ways to give birth and different places to give birth. Even within the US, right? There are, community-based settings where you can experience a different approach to childbirth and, be in different positions and have different people around you, or have a provider that you really establish a relationship with. So just to know that there's other ways for it to happen, and other ways it can look.
Okay, thanks for that. And Molly Fox has her hand up. Molly, would you like to ask? Molly was active in the chat as well, so I don't know if you're going to build on some of the questions there or have a new comment, but thanks for being active in the chat box.
New comments. Hi, Zane. Thank you for a great talk as always. I'm so interested in these ideas about how it would be adaptive for pregnant women to have some fear or anxiety around childbirth, because it would encourage them to seek out the necessary social support to, give birth in a healthy, successful way that Trevathan and Rosenberg have talked about and written about, and I see how it relates to what you did. And I just always wonder what are the implications then for this shorter gestational length finding that you found, that having greater fear of childbirth should be associated. I think we've maybe even talked about this question that just always plays on my mind before, is how could you have something that is potentially adaptive, but then is associated with shorter gestational length? Is there some benefit to having a shorter gestational length? It seems that all of the medical evidence would say that it's bad and that it only has negative outcomes. And the trade-off seems so small to say, let's just keep this baby in here for another week is, a really small price to pay for an enormous lifelong physiological cognitive benefit to the offspring. So I just wonder, how do we reconcile that something that looks like an adaptation then manifesting in something that looks so pathological?
Mm-hmm. Yeah, well, those authors are in the audience, which is amazing. But my response to that question is that perhaps it has to do with the level or magnitude of fear of childbirth, right? So I might imagine that, again, we're talking about a little bit of anxiety, right? A little bit of fear to where you seek assistance, but that's not to say that it can't get very high, right? And have pathological effects. So my interpretation would, from this data set is that people are experiencing more fear than is optimal in any way because of this sociocultural context. And so I would not interpret these outcomes as being adaptive. I would interpret them as, being an overactive defense response, having these adverse outcomes.
It makes a lot of sense, yeah.
Can I ask a quick clarifying question about your data set? So I know you mentioned compared to other studies in like other countries, the percent with fear of childbirth was much higher. Are there other studies in the US that are comparable? So is this a difference between countries and cultures, or a difference in what's going on right now with COVID? Like, which do you attribute it to more?
Yeah, I'm so happy you asked. So what's interesting is that prior to COVID, there are no studies that in the US that have used a standardized fear of childbirth measure to actually assess fear of childbirth. And so we don't have like that pre-post. And even if we did, our sample is not nationally representative, right? So I would be cautious about interpreting that anyways. But nonetheless, this is much higher than what has been discussed previously. Some of that could absolutely relate to the US versus COVID. I guess I do have data from a study which did compare fear of birth score among non-pregnant persons, like college students in the US and other countries. And again, I think it's a really biased sample. But nonetheless, the US college students had similar levels of fear of childbirth as, these other European countries, for example.
Thank you.
Mm-hmm.
So it looks like we had a hand raised from Allison Nolte. Allison, you can go ahead with your question.
Yeah, thank you for that excellent presentation. I thought that was so good. And going off of Molly's comment, my question about the length of gestation, I'm wondering if any of this, and it might come out in the next few years, can be attributed to the results of the ARRIVE trial, because I know that ACOG is now recommending that for women who are first birth and low risk, that they can have the option to induce labor at 39 weeks. And so just from my research on that, I know that fear of childbirth some of it can be alleviated if women feel that they have control over their birth. So I'm wondering if women with a higher fear would be more likely to opt into an elective induction in order to kind of regain that control.
Yeah, that's a great question. So we don't see any differences in induction in our sample in relation to fear of childbirth, but we don't have data on whether it's an elective, induction, or whether it's who's asking for it, right? The pregnant person or the provider. So we can't actually test that hypothesis, but that's a really interesting caveat that we can consider for our discussion. So thank you.
Yeah, thank you.
Just to raise one question I saw come up in the chat box from Molly Fox a few minutes ago, which I think might be a clarification issue, or just interesting follow-up to one of the previous questions. Are the pregnancy-related anxiety and pregnancy-specific anxiety scales measuring something different from fear of childbirth?
I think they overlap a lot, right? So because a lot of those scales are asking about, like, are you afraid of the upcoming childbirth? But some of them are also asking about how you feel about your pregnancy more generally, right? So it's a little bit distinct, but I think they're very highly overlapping constructs.
We have a question from Karen Rosenberg. Karen, go ahead.
Oh, hi, thanks. That was great, Zane. I really enjoyed it. So I was thinking in terms of Molly's question, and maybe Wenda's here too, so maybe she'll pipe in, that I think that our argument would be that exactly what one of you said, which was that a little bit of anxiety could be really beneficial, but a lot of anxiety could lead to problems. But to make it worse, the kind of clinical and unsupportive settings that women are giving birth in so much in the United States are really working against sort of this tendency to seek, right? Women are seeking, emotional support, and they're getting the opposite, right? So that exacerbates the fear and anxiety, I think. And then the question I was wondering about was, do you think, I know you'll say, I think I know what you'll say, but do you think other animals have anxiety or stress at this time? Obviously, how would we know, but what do you think?
Yeah. How would we know? But, I'm interested in that question. So my, wonderful RAs who I mentioned, I had them try and look that up a little bit. And certainly there's evidence for behavioral changes around parturition. But I don't know. I just think it's too hard to tell. Yeah.
Measure stress? Couldn't we measure stress?
Yeah, so there are certainly a lot of studies. So I mentioned just the cow transport study, but there are horse transport studies, there's rat studies and pig studies and all these different studies where if you stress the animal in various ways, whether it's transport or lights or noises, parturition is slowed, and those effects are mediated in part through stress physiology changes, all of which are a little bit different in these different species because parturition proceeds a little bit different in these different species. So I think there is more to do there. I just haven't figured out how to do it yet. I was trying to make an argument about that for this talk, but I haven't figured out how to put those pieces together yet. So I'd be happy to talk to you about it and figure out a way.
I would love that.
Hey.
This doesn't necessarily relate to birth, but when I was a PhD student, I studied ring-tailed lemurs, and we measured stress. It was social stress with these kind of self-directed behaviors, like scratching and yawning and teeth grinding and things like that. And so, there's some behavioral responses that might be different from cortisol, as a hormonal response.
Yeah, that's a good
just throwing out one idea there that's more of a behavioral measure of that. And it'd be interesting to see if other animals in a social group also are stressed or altering their behavior in any ways. I don't know. Ann Pusey's on, maybe she would have a comment about that. I saw Sonia Cavagelli as well, who was studying those ring-tailed lemurs the same time I was, and might have some thoughts on this. Go ahead, Ann.
Well, we're looking again at chimps with our sort of 50 years from Gombe, and they take what people are calling maternity leave, so they disappear from the group before birth very often, and some do it more than others. And I want to take another look now. Now we know more about rank and things like that, and who's natal and who's immigrant, and so I don't really have answers for that, but they do withdraw, it seems, from other chimps. So and of course, because they're withdrawn, unless you're actually following them when they withdraw, you don't really know what's going on. But that has been seen a couple of times when someone was actually, a guy called Bill Wallow followed chimps for days before they gave birth. And there was one female he followed who she did withdraw, and she was looking behind her, looking to see if there were other chimps. And then she made this nest, and she kept very quiet when she heard others calling. So they're worried about other chimps. and other chimps will kill their babies. And so they have a good reason to be worried. So I guess that's what I can tell you about chimps so far, but stay tuned because we're looking at it again to get some more detail.
Along these same lines, Molly Fox had asked in the chat whether other animals have assistance during birth. Does anyone have any evidence of that they could share?
I feel like Wenda and Karen have written more about this.
Go ahead, Wenda, if you'd like.
Unmuted.
Yeah.
Now I am sorry. Thank you, Zane. That was terrific. It seems to be a little more opportunistic. It does not seem to be as routine as far as we know, but it's a classic example of absence of evidence is not evidence of absence. So I think the more, when we made the statement a few years ago, I guess it was I that made that statement, sorry, Karen, that assisted birth was more or less unique to humans, although even then I didn't use the word unique, but it was seemed to be limited to humans, at least as far as a routine kind of thing. And since that time, over the last 20 or 30 years, more and more reports have come in. And I like to think that part of the research, that asking the questions was due to my challenging people by saying that this was an unusual kind of thing for other animals. So we found a lot of examples, but I don't think I've found anything, at least reading the literature recently, that suggests that it is as routine as it is in humans. But there may be other explanations for that kind of thing also.
Great, thank you. So there's a couple of questions in the chat on health disparities that I wanted to ask. I'm going to ask them together just because I want to make sure we get to both of them. But Kristen Abernathy had asked, are there issues with access to alternative birth settings with regards to race and class? And then a little bit later, Anishka Bandara had asked what things can or have been done to reduce socioeconomic differences in fear of childbirth. So different questions, but both related to health disparities. So curious to get your thoughts on those.
Yeah, so first, alternative birth settings and health disparities. So, as I mentioned, 98% of births take place in the hospital. The remaining take place in freestanding birth centers or at home. And so people's access to freestanding birth centers and home birth are very greatly constrained based on where you live and your insurance status and how much money you have. So as an example, home birth is not covered by pretty much any insurance, I don't think. So half of births in the US are Medicaid funded. So that means that half of the people who are giving birth generally don't have access to a home birth because you'd have to pay for it out of pocket. It could be several $1,000s. In terms of freestanding birth centers, they're very limited. Like many states, such as Vermont, actually where I live, there's no freestanding birth center in the entire state. And there's lots of legal reasons why they don't exist in more places that are problematic. But I think that increasing access to these community-based birth centers would be very beneficial for a lot of people. But oftentimes, if you're lower income or minority, you have less access to these sorts of resources. And then I can't remember the second question, sorry.
Yeah, so it's what has or can be done to reduce the socioeconomic differences in fear of childbirth. So what actions can we take based on the information we have?
Yeah, so I think that in general, trying to increase access to community births and or more supportive models of care, such as that found in midwifery, which is more person-centered and where individuals tend to establish longer-term relationships with their providers, can be really beneficial. Trying to address a lot of the structural racism that's kind of inherent to like the obstetric system in the US. As an example, like the father of American gynecology is Marion Sims, and he practiced on enslaved women in the US, right? But until recently, there was a big statue of him in Central Park. So in short, I think that trying to provide more supportive care environments. There are a number of Indigenous and Black-led, like midwifery, community-based birth centers that are popping up in different places in the country. So providing funding and access to those sorts of spaces where people can get more, supportive care would be really beneficial. There are some studies a study that came out last year, for example, showing that patient-provider racial concordance was associated with better birth outcomes. So Black women who had a Black provider had better birth outcomes than if they had a white provider. So yeah, increasing access to those sorts of things would be beneficial.
Great,
Wenda.
thank you. So we do have time for a few more questions. If people have questions, do feel free to raise your hand. We love to hear from you verbally, but we can go back to the chat for now. So
I see Wenda's got her hand up.
Oh, yeah, sorry, I did not see that.
I
Wenda,
can't
go
find
ahead.
that little hand on my computer, sorry. I was curious, Zane, about the finding that fear of childbirth in your sample at least was not associated with higher frequency of cesarean sections. And I'm wondering if possible, that could be due to the fact that elective surgeries were simply not done during COVID. I'm speaking specifically about the COVID times. And also that people may have been more afraid of COVID during a surgical venture than they might be of whatever a vaginal birth would be. I'm just curious about that, whether or not you might find slightly different relationships if you weren't doing it in COVID times.
Yeah, great question. So we talked about that a little bit as a team, trying to figure out what interpretations for this could be. And one of the ones we came to was exactly what you mentioned about how perhaps individuals were more afraid of catching COVID during the cesarean, right? So it's not, we certainly think that in this instance, this finding may be representative of COVID and not necessarily representative of pre-COVID times. But certainly, yeah, individuals may be more reluctant to undergo that elective procedure because they're afraid of catching it. And in addition, though, on the flip side, you know, there were some individuals who viewed cesarean maybe as even less risky because they thought that they'd be in and out faster. So they were less afraid of catching COVID through cesarean than if they were to go through a vaginal delivery. So that could also be kind of, you know, affecting the results as well. It was definitely a unique time.
Great, thank you. So pulling one question from the chat that I think is really interesting. Emily Andrews had posted and prefaced by saying something of an opinion-based question, but you touched on how some of the fear of childbirth comes from media representations of birth as very painful, difficult, etc. So how much of that do you think is due to overrepresentation of men as writers and directors in visual media? And could we kind of counteract some of that by putting women in those occupations? And then later in the chat, I did want to note that Chin-Yu Chen said that in their experience, the most terrifying childbirth narratives were told by mothers and health practitioners, and the mainstream narratives actually were reducing the pain. So maybe there could be cultural differences. So what's your take on those different questions about media?
Yeah, that's an interesting question. So, I mean, I can't speak to the gender representation of the writers and how that affects depictions of childbirth, although that seems like an interesting study to do. That'd be, yeah, an interesting one to break it, see if you could break down like the genders of the writers and kind of score somehow the horrendousness or representation of the birth experience and see if there's any correlation. But I also agree with that latter point that a lot of times people tell really horrible birth story experiences. And I almost feel like that's another cultural thing where people, you know, when you're pregnant, everyone just wants to come and tell you all the terrible things that happened to them in their childbirth. And I've also noticed on the other side of it, I mercifully had a very positive experience. I had a great birth experience, but I feel uncomfortable saying that to people because I feel like, you know, if someone had a bad experience, I don't want to be like, oh, mine was just great, right? And make them feel bad in any way. And so what it means is that I feel like I'm less likely to share my birth experience because, you know, there's this, I don't want to take anything away or make anyone feel bad that had a negative experience. And so I feel like there can be a bias in terms of like what gets shared, right? Because of course you want to provide a space for people to be comfortable talking about their negative experience, but it means that the sample that you have is not representative of all experiences. Yeah, Wenda?
I was just going to add something to the media thing. After I gave a talk once that had someone talking about fear of childbirth, Jillian Bentley asked me if I had ever seen Call the Midwife. And at that time I hadn't. And so I immediately became a binge watcher of Call the Midwife, and I love that show. And it seems to me that might be something for a person who was ambivalent about whether or not she was afraid of childbirth. might get some positive stuff out of it. It runs the gamut. Of course, there are all kinds of births that are not so good, but most of them are good. And you see this woman in utter misery, it seems, and just grimacing and everything like that. And then all of a sudden, there's this instant transformation with this amazing pleasure and happiness. And that seems to me it would resonate with a lot of people.
Yeah, thanks for that comment. I also have been reading Dick Grantley Reed's 1933 book on childbirth without fear, which has been really fascinating. And just seeing these things he talks about like the importance of the provider not cueing patients to basically have fear or pain, right? He's talking about all the passive ways in which the people around you in the birth environment can cause you to become afraid. And so I think that that's really informative and interesting. All these subtle cues of people, all these little things that people say just really add up and make people more afraid, and undermines people's confidence. So, I guess it's a whole cultural shift we need in terms of how we think about and talk about childbirth more generally.
Okay. Oh, okay, Karen. This
I
is
just
the
wanted
last question.
It's not really a question. I just wanted to say that this idea that you could maybe make some inferences about gender based on the representation of childbirth that you see is something that Wenda actually did in a prehistoric context when she was looking at a membrane pot and people were interested in whether they were made by men or women. So American Antiquity, am I doing a good ad for you, Wenda? I forget the year, American Antiquity.
Okay, hopefully someone can paste that into the chat box before we have to close out. Sounds like an interesting article. Okay, well, thank you all so much for joining us today. Zane, thanks for a great talk. And that was really fascinating and interesting. I had some students from my class attending today as well. And so I'm glad to hear that you had some students from your class and from your lab participating today as well. And I hope you will consider evolution medicine and public health for publishing your results. We'd be very happy to receive that from you and your collaborators. Okay, before we totally close out, I want to just quickly share with you the upcoming Club EvMeds. Let me try to share my screen. Hopefully you're seeing our Club EvMed website. Here's the great talk that we heard today. We have on April 21st, so that's a couple weeks from now, we're going to be hearing from Beth Archie and Chelsea Weibel on a paper that they recently published in PNAS, which I think a lot of you are going to be interested in. It gets at issues about predictive adaptive response, or the terminology often used as life history strategies, and how whether those might be modified by early life experience. After that, we have a postdoc spotlight, where we're going to hear from 3 different postdocs. We're looking over some of the nominations right now. We have a great collection of nominations for the 3 spots we have for that. And then after that, we're going to have a conversation about another PNAS paper moderated by Dan Blumstein. This PNAS paper, The Pandemic Exposes Human Nature, 10 Evolutionary Insights. We're going to hear from 3, I think actually maybe 4 of the authors on that paper and their perspectives, which I think will be really interesting. You can see it goes on from there, and we're actively working on the schedule for this summer, probably 5 or 6 talks. So with that, I'll just thank you all again. Thank Zane for a fantastic talk and really stimulating discussion. And we hope to see you guys again really soon. Thanks for joining.
Thank you.